Well, good afternoon, everyone. This is Victor Kogler from CIBHS. I'm joined here today by Amy McIlvaine, and we are going to go over the spreadsheet for forecasting utilization and revenue. And what we'll do, I'll show some slides. We will be toggling back and forth between the PowerPoint and the spreadsheet. And because we have a small group, we will I'll leave the microphones open so that people can speak if you've called in on the phone. So I will do that now. Unmute folks. I would also like to say that if you are on speaker, or if you are on speakerphone and have not muted the phone, if we get background noise, conversations, and whatnot, I may have to mute everybody again, or unmute just for the question. We do have a question box, so you can feel free to put a question in there if you want. We'll make sure that that gets responded to. And I think with that, we will get started here. We've got, it looks like everybody who registered has signed in. So that that looks good. So, all right. So we're going to go over some of the material we discussed last week, just very briefly, just to reinforce the, sort of like a quick review. And then we will go through the spreadsheet in detail. So with that, we will get started. So this is the model we have for outpatient. We have a separate one for residential services, which we'll be discussing Monday. And so with that, so first off, just to briefly go over what the components of the model. First off, your budget, and what is your cost of doing business. Now, given the sort of work we're in, and particularly in outpatient, who knows? As much as 80%, perhaps even more, possibly, is going to be staffing. And that's the work we do. It's person-to-person kind of work. The budget. Well, we'll talk about that when we get into it. But it's linked to, more or less linked to the SAFSI budget template, which has changed slightly a few times since we first set this up. And then I think the key thing here is to identify, what is the true cost of doing business as a provider of outpatient SUD counseling services, which meets, just general quality standards as well as requirements of the DMC ODS waiver. And then another item, which is, are these costs allowable? CMS has a 2-volume, very lengthy provider reimbursement manual. I will send out the links to that for everybody after the webinar. And that describes what Medicaid will and will not pay for. And when I first looked at it, I was surprised. It pays for a lot of stuff, And so I recommend you be getting familiar with that. It looks a little daunting at first, but then you'll see a lot of the categories of chapters deal with things that are just not part of our world. Durable medical goods, end-stage renal disease, skilled nursing facility costs, hospitals. So once you sort of get a sense of how it's organized and see where you need to and I'll do some of that for you to show you where you need to look. You can see what's allowable under federal guidelines. Now these are federal guidelines, and I would, if you I don't know what to say, getting creative here, I would recommend you check with SAPC just to make sure, because they could have more restrictive requirements. So the other part of this, and the other is operations. So we start out with the foundation of the funding to support the services, and then so what are the program services? What are you doing, for clients? What does service delivery look like overall? And then how is staff time allocated to cover the activities that you'll be doing? So let's see here. So I said some of that, the additional cost for the waiver, and as the budget will reflect, as SAPC said, that higher rates equals higher expectations. Well, but also there's higher costs and more staffing and more quality for you, and that needs to be reflected. And then we'll get into this, but we'll talk about the importance of identifying staff who provide billable services. So let's see. All right. Well, with that, bear with me as I now go to Excel. So here's the budget. This is one which I did as a generic outpatient treatment model. This is based on actual provider budgets, although from the Bay Area, not LA. I'd be happy to put in some LA specific numbers. And so, what we have here, so first off, the first one is direct salaries for staff providing billable services. So what we have, I think, is, again, what I've seen is fairly typical: program coordinator. You got some counseling staff, counselor 2, counselor 1. Alcohol and drug counselor 2 with a bilingual differential. Now you're going to, LA County's got, I think it was 13 out of 14. I'm sorry, I just had to mute everyone. We may have to just ask questions to the question box to because of the background noise that most of you, I'm sure, just heard. So there's a bilingual differential. I mean, that's not uncommon that somebody's got that has and uses in the job by their bilingual skills gets paid a little extra for it. So here it's like about $2, a little less than $2 an hour. That may be a little high for that. I don't know. Something you might look at is what the county does. This is where I got it. Most counties will pay bilingual staff a differential. And you can see what the percentage is there. Then we've got an MFT, your LPHA, but this is in their capacity as a therapist. Again, these are staff providing billable services. And so you may have on the staff an LPHA, in this case, the hypothetical MFT, but they may also have a caseload where they are, dealing with, clients with co-occurring disorders, perhaps doing family therapy, whatever. So they're here.
Excuse me, Victor?
Yes,
this is Amy. I have a suggestion too, because one of the things that I had a lot of questions about was just some of the real simple things on this, but they're not always simple, is just talk a little bit about Schedule 1A and the idea behind whose direct salary, wages, and benefits. And then the other thing that some people get tripped up on is this abbreviation, FTE, which means full-time employee, and then how you allocate more than anything, like how could a program coordinator be only 0.5, a half a person, and then, kind of just let people know that it's also allocated below in Schedule 1B in the indirect. But I find that, even clarification on that up that high level is important sometimes.
Oh, all right. Thank you. Okay. So first off, so what SAPSI's definition has been like direct service, direct salary staff are those people who are interacting with clients. And I think it's pretty good, conformance with the way I'm defining it here. And maybe if at some point linking this to the SAPSI budget template may not make sense, in which case I'll use different categories. But the critical thing is you identify staff who are doing billable work. These are the folks who carry the organization, through reimbursement of the services they provide. So you want to make sure that you have them, that they are highlighted in the budget, and also they will be highlighted elsewhere as we go through the other pages of the spreadsheet. So those are the folks who bring in the money. Like I say, their work carries the organization. FTE means full-time equivalent, and you can have things where you could have two FTEs for the counselor 2 here, and that could be 3 people. One person who's full-time, 2 people who are half-time. So it's not looking at individuals, but rather the hours. So, a full-time equivalent would be 2,080 hours a year, 20 hours a week, or, just do the math. But, what proportion of a full-time employee is in the budget here? And so those words in the budget, so the program coordinator at halftime could be your QA manager. It could be program coordinator for a the Department of Children and Family Services contract. That's totally unrelated. It's basically, this reflects how you allocate your staff, or deploy your staff throughout your agency, and so there's somewhere behind here could be other services you provide with different types of funding, where the and particularly as we move down into the indirect, the non-billing staff, we'll see that we don't have people. I think there's only one person there who's full-time. So that simply reflects, like, if we want to take a look down there, like the executive director, maybe the DMC program is only, 2/3 of the agency budget. Don't take that literally, because there are other ways to allocate, costs. But so they're there for 65%, and they spend the rest of their time, with all kinds of other stuff. So this, being the executive director, working in that capacity for other projects within the agency, fundraising, board meetings, donor relations. You've got donors, that sort of thing. So this is the amount of time that somebody is allocated to drug Medi-Cal services, and so it's not intended to reflect their entire financial or physical presence in the agency. And maybe,
and Victor,
maybe. Yes.
One other question that sometimes people get is, if you're in a small agency, your executive director could also be your MFT, your in the therapist capacity above. So it might be that 50% of the time they're spending in front of the customer doing direct billable services, and 50% of the time they're doing indirect activities. But the thing that I think is so cool about the Schedule 1A is that you really want to focus on that face time that these folks are having with the customer, because this information is really important to a tab that Victor will show you later on in the spreadsheet, because you use this information to calculate on another sheet.
Right. So, yeah, I mean, these folks can be, and I'm sure you all know how this works, thinking about your own organizations. People wear different sort of hats. I mean, like, up above here, I got the program coordinator, but they're also doing billable work. They're like the lead counselor, the person who's, the facility manager perhaps, but they're doing billable work. So there's all kinds of ways, depending on the size of the organization, that you will assign staff, individual people, and to different task areas. I think we can see more of this in Schedule 1B, the non-billing staff here. Nobody's full-time except for your outreach worker. So now these could be your finance manager, your office manager, your QA compliance manager. They could all be the same person. Or no, wait, there's too much here. But one person could be your QA and compliance, because it's 50-50. Although I show here the salaries are different, but this is, it's however you do it. One of the reasons I have this here is kind of to a certain extent, a teaching tool that to make it clear that these are mandated functions. So you've got to, maybe not all mandated, but functions you have to have covered to be successful in the waiver. You've got to have a QA manager. You've got to have a compliance manager. You don't have to have IT manager and IC support, but I mean, that's not a mandate, but I mean, it's realistically speaking, you've got to have somebody who can do that. Support would be stuff like data entry, whatnot. You may further have a contract that would show up elsewhere in the budget for people to manage your network internally. So these, now where we part companies somewhat with the SAPSI template is here with the UFT. So in this case, they are not having client contact. The clinical supervisor, as the LPHA, they're signing off on medical necessity and treatment plans, which they can do. Now they could do it, with the client, or they could do it just simply with in a meeting with the primary counselor for the client. So this is not necessarily billable in this case, although I think SAPSI may call them the direct staff because the client contact. So again, it's the importance of highlighting people who do billable work versus people who don't, or the amount of time that an individual does billable work versus the time they're doing something else. So your QA manager could potentially be your program coordinator. As I say, it's your agency, and you know how you've got staff deployed and how you assign them to different tasks. It can get a little bit complicated, but again, the basic question here is, can you bill for what they're doing? And if you can bill for everything they do, great, then here they are. If you bill for, half of what they do, then they go down here. Or, with your outreach worker, if you can't bill for anything they do, they would go here. And I include the outreach worker there. Now, clearly, you're not going to be able to bill for, your IT support. But you've got something, a function here that I think is really important. This is just me. You can decide otherwise. That somebody who can go out there in the community and motivate clients to come in for treatment. We don't have the courts doing that for us to the extent that they did, and so how do we do that? And so that's why I put them there, is that you could have somebody there who has client contact but is not doing work that's directly billable. And So anyway, that's, you can put your benefits here, whatever they are. And here's, if your benefits are actually 28%, put in 0.28. There you go. It makes a change. So there we've got, so that's all your staffing costs. This is pulled just directly out of the SAPSI budget. Facility rent or lease, equipment or other asset leases, your copier, your van, whatever. Direct and indirect operating costs, however those are determined. Again, this is just to make it a little simpler for folks to pull a number out of the SAPSI budget template. And then lastly, your indirect costs. And then the total of all these categories is there, 1.47 million.
Victor?
Yes,
it's Amy again. I have another question. Question I get off.
Hello? Oh, I think we lost Amy.
Okay.
Are you there?
Hello, I'm here, Victor.
Yeah, okay.
I do have a couple of questions, a couple of comments that I want to add again, just because I heard a lot of people ask this and want to make sure that we cover it, is what do we do with our medical director if they're not actually hired by us, but we have a contracted person who may only work a certain set number of hours for a flat fee? Where would you put them in the spreadsheet?
Well, I actually, they would go into your services and supplies. If that's a contractor. I mean, they would be, are they an employee? Are you doing a W-2 for them, or is it a 1099? Ultimately, that's the, so in many cases, I think most people will have a physician on contract to do that. And and the point I like to make here is that going back up to your billing staff is that you get 1.4. Let me round up. It's 1.5. Okay, everybody. And so you got $1.5 million budget, and again, it's the work that these 7 people do that brings in the money to the need that has to bring in 1.5 million. So that's and that covers rent, your copier, indirect, all this other stuff, phone, office supplies, et cetera, and so you can again, it's a cost of doing business is what has to be in that budget. What then we will find out shortly is whether these 7 people can do enough work to bring in that 1.5 million. So if there are questions from the audience, again, I had to mute everybody because there was some rather loud noise coming from somebody, and I can't tell here, where it might be coming from. But if you want, you can enter a question in the question box there on your little control panel on the right-hand edge of the screen, and we will answer that. And if we otherwise, then I will move on to the next page in the spreadsheet. So we will pause.
Yeah, and I'll monitor the question box. This is Amy, and also if somebody just ends up doing it in the chat box, that's fine too. And then one of the other things that I've just told people is, what you just need to kind of look at with these position titles, if it's more comfortable for you to even add lines and list, if you have alcohol and drug counselor 2s and you have 3 of them and you want to be more specific about it, because, just take out your payroll sheet and make sure that everyone is accounted for, and what some people that I've worked with will do is like program coordinator, they'll just put a little dash and then they'll put the person's name in there. Just for starters, there's two good things about this. I like to, when we start looking at processes, and people have heard this from me, I like to talk about people in terms of their position title so they don't take things too personally. But when you're filling this out and you want to make sure you've got everybody accounted for, you may need to just add names so you know that you got everybody in the spreadsheet. And I believe, Victor, the way this spreadsheet has been set up, you can actually insert lines, making sure that you don't mess with line 14 and 15. It'll still calculate. So insert your rows 13 above if you want to add, because there was actually one organization that just went in and entered line by line right off their payroll sheet. And that will work. It will not mess up your formulas, and it won't mess up any of the tabs throughout the template. Mm-hmm.
Now, that's a good point. Thank you, Amy, because I intentionally did not put any protection or into this so that you can modify this as see fit. Now, of course, if you do have the extra rows like I did, you'll need to copy the formula here so you get the totals. So you get, 1 FTE at, 1850, and it'll calculate the amount for some. Also, what I would like to say is that, we can be of assistance to you as you fill this out, either, for any part of it. If you say, well, I'm sure I got the budget right. So, we'll talk to you about that. So this is not your only chance here. This, I think, is sort of an orientation. After this, is put some numbers in there. And, put your numbers in there, the real numbers. And, and we can walk through this together individually with you. That's what this, project is all about. To make sure that, to interpret the data, to make sure that, you have everything, and just have somebody else to bounce my, ideas around with. So you're not, on your own here entirely to do this. It's clearly, you've got to put the numbers in there because I don't know what they are. I just kind of, put some stuff in here. I needed to populate the spreadsheet with some numbers. So they're generally in the ballpark, but you need to, this is your organization, your cost, and we can start from there with you, and see how it plays out for you. So all right, look, we did have a question. Do you see that?
Yeah,
Amy?
we do. Yes, it says, is this settled at cost at the end of the year? Are we moving into a fee-for-service contract? And what I would like to recommend, I think this was a really good question from Juan, is there, on the SAPSI website, there is one of the buttons that you can push on is updates and announcements. And on October 5th of 2017, there was a SAPSI bulletin number 1709 that was published that really does a good job of summarizing how costs will be calculated. And it said, while payments shall be made in accordance with the fee-for-service rate set out in the attached rates and standards matrix, the contractor must produce proof of allowable costs. And you also have to make sure that it will be cost reimbursement, not to exceed charges and excess payment, or you could get recouped. So it's not a classic fee-for-service, but this particular bulletin really does a nice job of explaining that. And I am going to cut and paste that link into the question box so people can access it.
Amy, it'd be better to put it in the chat box because we're only going to see the question. Right. Very important point there too, because also what I would say is that the, Medi-Cal, this is now Medi-Cal. Actually, Medicaid is the national standard. Costs are settled at the end of the year to lesser of costs or charges. So if you, you'll see shortly what that'll look like. So it's, whatever, if you're, if what you bill is in excess, say you bill for $3 million and it actually costs you $2.5 million to do the work you did for over a year, you owe $500,000. On the other hand, if you billed for $2.5 million and it actually costs you $3 million, you have to eat that. So an important thing to consider, and this is one thing the spreadsheet will help you identify. I also don't presume to speak on behalf of SAPC, and if there's questions or there seems to be inconsistencies, do let us know, and we'll try to clear those up as quickly as possible. So, all right.
Yeah. And there is one more question, and there is one more question, Victor, before we move on. It's with the need of qualified treatment providers in the new system, how can an agency get these qualified staff with a budget of $80,000?
Well, maybe your budget has to be $850,000. Now, that's a challenge. I think that there's going to be, particularly for bilingual staff in whatever language, whether it's Spanish or Tagalog or Armenian or Farsi, there'll be a premium there. And I think there's a situation. We have a situation where there's going to be this sort of kind of competition, or and it's not direct competition, but if provider A pays a bit better or has better benefits than provider B, if I was looking around, provider A is where I'd send my resume. So that's it's one of the things that the waiver has done is to open the door to all kinds of, and we're not going to get into this, but maybe some other time, but to all kinds of marketplace forces, both for clients and providers. And that's not something we've really had to work with in our history here in California. So that's the thing. And if you already set your budget, I don't know what provision there is for modifying it. At this point, we're 4 months into almost 5 months into the waiver now, and so I'm not sure what provision SAPC has for making mid-year adjustments. But I see it's in other counties.
Victor, I think that it is appropriate if, and one of the things that I think this was Joseph had the question, and it is a really good question about this budget. Because there's been, on the flip side, some people have actually been asked to budget higher than they think they can reasonably provide services. But SAPC is looking for an estimate or guideline, and you can spend less or spend more. But again, you just have to justify, how you spent your money, and if it was providing services, and then you had costs and expenses that equaled that, or that were considered, the necessary. But you could go back to your finance person and check that out. But then the other thing that's going to be very interesting as we click on some of these tabs is you'll be able to see then if you're providing services in excess of your budget, you would have that information and data to go and talk with SAPC about why you needed more money. And we have 2 more questions. At the end of the year, if the revenue exceeds the budgeted expenses, agencies will have to pay back the money, correct?
Yeah, I think that's basically it. Now we can, I don't know whether SAPC, again, it's that lesser of cost or charges principle. That, if you bill for more than what it costs you, you owe somebody some money, and that's, and I think that's, if that's an unclear thing out there, then we should talk with SAPC Finance and make sure that they issue a clear statement on that. because I certainly don't want to mislead anybody. And like I say,
right.
This is a long-standing principle in Medicaid, and you know, I don't think SAPC would be doing anything different, but you know, they should make that clear to folks.
Correct. And there
right.
is a list of things that are allowable. Well, there is a couple of, there's follow-up on that is, I believe we can only modify the budget by 10%, and that's about right, although I've even had a few folks that have had to modify a little in excess of that. So talking with your financial analyst is always a good idea. And then there was a comment that it is very unclear, and I think that's extremely true. But so for me, it's always really important to go to those monthly mandated meetings, because there's, you know, as things progress and things become more clear, they do disseminate that information there. There's also the QIUM meeting on Wednesday, which is a pretty good place to toss out questions and try and get answers. But this whole idea of budgeting and how much people really need, and if you do have excess funds, there is a list on the website of some allowable expenses, because SAPC does encourage you, for instance, to make sure that you're paying competitive hourly rates. So it may be a good, if you're finding that you're having a lot of excess money, you may want to do a salary adjustment. You know, Victor suggested an outreach worker, and some of those folks are allowable, and that it's those positions that you could bring on if you're making additional revenue.
Right. Thank you. And I have to say, I mean, SAPC has been, you know, compared with other counties that I've worked with, has been gone to, I think, extraordinary efforts to make themselves available to providers, you know, to help them problem solve, answer questions, to clarify policy. And I think you've got these venues that Amy was talking about, the phone calls, the monthly meetings, where you can ask these questions directly. And so I think that's a huge resource, and I urge you to take advantage of that. So let's move on here. So we got, you know, so here's what it costs you to do your work. You know, again, we'll round up to 1.5 million. And now, what do you do with it? And so on the second page is your service model. And so this is out of the SAPC billing matrix, most recent version. The different billable services, the HIC codes, just for, you know, just to have them there. How many 15-minute sessions per unit? Although I understand group can bill at on a per minute basis, but to keep this simple, we'll use 15-minute chunks of time. And then the cost per unit. These are SAPC's rates here. So anyway, that little comment explains my rationale. This is also divided, and I like to get people's feedback as they work with this. So the regular treatment services here, and then we've got the recovery support services. And because this tends to operate or look like a separate program, even though you may have some of the same staff, you know, doing this. But anyway, looking at treatment, what I did is I have to say fairly arbitrarily plugged in numbers here. You know, so assessment or intake, that's 8 units in week 1, so that's, you know, 2 individual sessions. 4 units, 15 minutes each for treatment planning in week 1. You know, so that's 1 hour. It's 6 units per group, so that's 3 groups. I think this is probably getting a bit much, but and this is for a 16-week, 4-month primary treatment episode. You know, and so you'll need to put in your own numbers here. Again, I need to populate the spreadsheet to, you know, demonstrate the relationships here. But, you know, so for example, this is total units per week. So that's 41 units. That's 20 hours. So that's probably unrealistic. I do. More than probably. So these numbers would need to come down. So you divide those by 4 to get the actual staff hours per week. Anyway, so you would fill this in for whatever you actually do. Now this is on a per client basis, and some people ask, well, why not for the whole caseload or for the And the reason I do that is it's just for consistency, because subsequent pages in the spreadsheet use the numbers that are generated here. And so if you say, well, this is just my total thing for the whole caseload, then calculations that happen in subsequent pages will turn out. Actually, somebody asked me to look at one once. I thought, wow, this is, it was really, and that's what they did. And they couldn't figure out, it looked so far out of line that they, so it's the mythical, typical client, what is their treatment experience? Now I understand we're talking about, patient-centered care and not, medically necessary services and not program-driven services, where you go, there's so many things you got to do every week, one group a day, and and people have different needs. Some people may need more individual counseling up front before they get into group, whatever. So you are, again, free to adjust this in any way that you want. I think really probably the only way that you wouldn't necessarily add more services here, but you may want to add more rows. Maybe it's 20 weeks, 24 weeks. Again, so just add rows, change. You're going to have to do a little work here. Change the row headings and add that in there. So this is just my own thing here. It's arbitrary. It's 16 weeks, and you need to think about, in general, and this is what makes it a little bit tricky. We talk this time next year, you're going to have actual data. You will know what the sum total of all this individual treatment planning, client-centered stuff looks like, after 12 months. And so even though this would probably not reflect any given client's specific treatment experience, in the aggregate, for all the clients you see, this is what tends to happen. And once you've got that, then you've got some solid data there to use for planning and evaluation purposes. But right now, like everybody else in California, it's your best thinking what this looks like. So anyway, so in this case, at the end of 16 weeks, that the patient is discharged and post-discharge recovery support services begin. So then that's over here. And I, just fill those in. And again, you can put in whatever you want. Along the right-hand side here in column S, we've got the total units per week. So again, divide by, well, I do that further on, but and if people would find that helpful, I mean, let me know, because I can add another column, total hours per week, because that's really, your staff don't work in service units. That's not what they put on their timesheet. They'll put in hours. So if anybody would like to see that, actually I may do it anyway, is add total hours per week. And so then what happens is everything gets totaled up down here at the bottom. So, for assessment intake, 12 units total per client. So that's, 3 hours. It costs $356 at, you know, the $29.63 rate. It's 3 sessions and 3 staff hours because it's an individual session. You know, it's one-on-one, so 1 hour is 1 session. And when we get to group, so there's 192 units at a cost of $5,689. This is per client. It's 32 sessions, which are an hour and a half, so it's 48 staff hours. So anything that's done in a group setting, you're going to have multiple staff hours, generally speaking, per session. So the session is, you know, what the client experience is. You know, they come in and they come to an hour and a half group. And the staff hour reflects the amount of time that your counselors spend delivering that session. And as I say, for individual counseling, it's a one-to-one relationship, but for group services, it's you know, more staff hours than sessions, because the session is more than an hour. And so then this just gets, you know, runs across the bottom here. And then this is what the total is. Now, what I'd like to hear from folks, if you would rather have recovery services, and again, I tend to think this might be better. You know, they're in here because I'm figuring you've got the same staff doing the work here, but we could break this out more more distinctly as a separate program, so you can get and I'll show you what the reason why I think in the next page. But anyway, so the total cost here. So the total units for a treatment episode is 600 units for the, you know, the quote typical client. Costs a little under $18,000. It's 136 sessions. So they're coming in the door 136 times to receive services, and it's 153 staff hours. Just delete that there. So that's, you know, per client, per patient, is what that looks like. And then we'll see as we aggregate that for the entire caseload over the course of an entire year, what that tells us. So Amy, do we have questions?
We don't have any specific questions on this one, and I did answer the questions that were individually distributed for people to follow up if they want questions. I do have a question, though. When we're looking at this spreadsheet, we talk about total units of service, and then you have the next line on 58. It says total cost, but that's really because we're looking at cost, but it also reflects the dollars, the reimbursement amount, correct?
Well, yes. Now, let me explain. So the 1,083 is you got 32 units, 32 15-minute units of recovery services case management. So that multiplies 32 times the rate. And that's the case for all these numbers here. When we get to the end, and some of you will see the formula, what this 17,954 is the total across here. So the total for each one of these types of service, each one of these HCPCS codes, adds up to 17,954.
And that's actually the amount of money that you know, you would traditionally sort of think about bringing in if you provide 611 services. The revenue that you generate is $17,954. I just wanted to clarify because on the first page we talk about, you know, cost, indirect and direct cost a little differently when we're looking at this description of total cost. So having people understand that that's the amount that you get reimbursed.
Yeah, you know, and actually I should change this because total cost is really a bit of a misnomer and should be total payment. So
okay,
if you
that
do
makes
all
it
this,
easier.
and every client is the perfect client, you know, and attends every session and, you know, sticks through to the full course of treatment, then you would get $17,954, ideally. Yes, but right, thank you, Amy, because that isn't your total cost. It's your total, theoretical total payment for doing this work, total reimbursement.
Okay.
All right, shall we move on here?
Yeah, we don't have any questions that came up. I know that this is probably one of the most difficult parts of the spreadsheet that I've heard people have, you know, said, how do I fill this out? And, you know, one of the ways that you can do it just for starters, if it's sort of daunting, is just take, you know, look at 2 or 3 different patients that you've had over the last 3 months and just sort of go down and track it. Take the first patient and just fill the sheet out using that information that you've already inputted into your system for a particular patient, if that felt like that was a particular patient. So you can actually use some kind of numbers that you've already collected. You don't have to, like, you know, dream this up.
Yes.
Because you'll notice that, you know, when push comes to shove at the end of this, when you're looking at it, you'll either go, wow, you know, we're pretty much on track, or you might say, ooh, we might have a problem. And then you can start to think about, well, we need to add more services and what is reasonable. You know, many people found that, you know, case management is one of those, you know, situations where you haven't really isolated that as a separate fee yet. So it's hard to kind of really put your finger on how many case management units you're going to have. But that's a place to start. Is you can take your past documentation, start from July, and just plug it in here.
Right, and that's something I helped a provider with early last year. Was they did have some data, but they weren't sure how to plug it into the spreadsheet. So we helped with that. Turns out they were doing a lot of stuff that would be now billable as case management. They also saw that they were, you know, basically did some intake stuff, and then it was all group. But we filled in what they actually did. They then made the assessment, like, well, would we do more case management? What about, you know, additional individual counseling or patient education? So again, you can make an informed decision, an informed guesstimate, you know, what some of these new services might be if you do have some data from last year or something. And again, if you do that, then let us know, and we can help you plug it in here in a way that makes the most sense, and we'll give you, you know, better answers. All right. So, did we get?
Yes, we've answered all the questions for this tab,
okay.
But again,
all right.
Victor is very good at helping people. Once you fill this out, in your coaches also, if you're involved in the, you know, the collaborative, they can sit down and help you with this. And some of them, you know, some of us have better expertise in other areas. Victor is always willing to have you send him a copy, and he'll review it and say, wow, this makes sense, or it doesn't. I'm perfectly willing to do that also. And then if I have questions, I just move them on up to Victor. But we certainly want this to be a successful process for you. So reach out and just ask us if you're having questions.
Yes, definitely. All right, well, then we'll move on to the revenue forecast. So we got, you know, you identified your budget, your projected anticipated costs for doing what you do. You identified here what on a per client basis, what the treatment experience and the ideal payments would be. So let's you know, put the key in this and start it up. And so the revenue forecast, basically all these yellow cells are calculated. And so what we've got here is the bold cells is you can modify, and they will produce changes elsewhere, on this page or the next page. So you've got the episode duration, which is 48 weeks, which includes both treatment and recovery support. Again, that sort of makes me wonder whether it'd be good to pull recovery support out separately. And we're just looking at the 16 weeks of the, I don't know. It kind of depends on what people think. The caseload per FTE makes a big difference. Duration of sessions, 1 hour for individual, 1.5 for a group. The average drug Medi-Cal patient attendance per group, and number of weeks per year. Here we calculate, so the 7 FTEs, this is brought forward from the budget of your billing staff, which we see right there, 7. Then the static capacity, which would be sort of like a snapshot of how many patients do you have on the caseload at any given moment. So that'd be 140. And then a dynamic capacity, 152 over a 12-month annualized time period. Now, if you were, so look at static capacity, if you change the caseload from 20 to 25, you just saw where that took a jump from 140 to 175. So that's, and you can see here, if we look down here, so look at the total, it's 3.4 million. If we go at 25 patients per counselor, we go to 20, it's 2.7. So direct impact on income. So anyway, so all your clients do what they're supposed to do. So we have here, let me go back here. So the service type, so these are the column headings, that we have in the previous spreadsheet up here. And so then we mostly taking from the totals at the bottom down here, what the total units at 15 minutes each, total sessions, and total staff hours per client. We then look at this on an annual basis. So, so for all clients, what is the, and basically we're just multiplying here, by your 12-month total caseload, the units here. Same thing for annual sessions, annual staff hours, and the staff hours are what we're particularly interested in. We then go from, so we got 22,452 staff hours to do all this work. We then look at the total reimbursement per client treatment episode, which again is 17,554. We call from down here. And so anyway, so we gross 2.7 million. Not bad. I put a little subtotals here. 1.8 million for treatment, and then 900,000 for the recovery support. Just again, another, and I'd just like to get people's feedback, on this, what they think about breaking that out. So now we start making adjustments. Is the no-show rate? I have 20% here. This makes a big impact. So 20%, you're losing a bit more than 500,000. If that went up to 30%, you're losing 800,000. If it went down to 10, yeah, not bad. You're losing, but I'll put it back up to 20. Disallowance and denials. A denial is you get when when the claim is submitted to the state. And you actually make it, there's a further step. I know that SAGE has procedures so that, for example, in the EHR section, if there's no case note, then that session is not billed. Or if there's a case note but there's no signature, same deal. So there may be situations where services that are recorded in SAGE don't even get written to the claim because they're missing something, or the client eligibility isn't clear. So they don't get sent to the state at all. The next step is they do get sent to the state, but they get kicked back, and maybe there's a typo or a transposition in a number, or you've got that the patient gave you a bad social security number, or on and on, or the client wasn't eligible. That is a major reason for denials. They weren't eligible at the time services were rendered, or they there are far fewer conflicts like this now, but there are still certain types of services that you can't you only do 2 of on the same day. And usually these are cross providers. Anyway, so those are the things, and you'll get a report that I'm presuming SAGE will produce, saying, well, here's the claims that went in and that weren't paid, and you've got to fix them. If the client isn't eligible, that's kind of limited to what you can do. Now, maybe it's the middle of the month, like the 17th, and you've got some time to get them signed up. Medi-Cal eligibility comes in 1 month's chunks. So if they go for a Medi-Cal interview today, and they get eligibility, I'm not sure how long it takes, but the eligibility starts on November 1st. So you could be, good. And then the disallowances, those are if you've been a Medi-Cal provider, those are the post-service, what happened in the post-service, post-payment reviews, where you've been paid. The state comes out and looks at the chart, saying, okay, you billed for, for Joe Smith here on November 17th for a group. Let's see the group log. Let's see the chart. And those of you who've been through this know the joy of this kind of thing. And so if their name isn't on the group log, well, forget it. If the note isn't signed, or if there are 13 people in the group, then that's disallowed, and the state wants their money back. And so that can, the thing about this, just like with an audit, the more they find, the more they look for. The deeper they dig. But I mean, on the plus side, this is almost entirely under your control. And if you've got, and this is the reason for having a compliance manager or quality assurance manager, that if you've got somebody checking these charts out, and SAGE makes it a lot easier because you can do much of this electronically, assuming you get all the features. Somebody needs to be looking at this to keep on top of it, because you're going to lose money. Again, this is $250,000 that you lose. So, and let's see here, we'll go back to the budget. Your QA manager only costs you $35,000. So, money well spent. Anyway, what your net is, is $1.9 million. So that's, I would certainly be working on that if I was a, ED. We go back to the budget. Remember the $1.47 million, and we still land up to the good. So you've got a surplus of $428,940. Now, what that says are two different things. One is, are you showing your full cost in the budget? It was $1.47 million. Or does it say, wow, well, we could hire another MFT because we got a lot of, co-occurring disorder clients, or whatever. So you could, there's a lot of different things you do. If you got, access to certain types of caseloads, veterans, you may want to hire a counselor who's got some experience in the military who can talk to vets. And, so anyway, there's one thing. Do you have, is that, are your full costs? And maybe they are. Maybe they are. Which then would say that, well, then maybe you don't need to be billing at the maximum rate. And again, we get back to this cost settlement, this cost reconciliation issue. If you're billing at the, let's say this is, you thought, well, I put everything I possibly could in the budget, and that's, we still end up, with a surplus. Then, that's the amount of money. Remember that, because you'll be writing a check for that at the end of the year. So then, and again, I'm not sure what SAPC's policy is on this, but I would think that and this is about a 20% discrepancy here, that, the rates need to be adjusted downward by about 20% in order to, come in closer to this, so what you're billing, ideally be a little bit more, so what you're billing is more in sync with what your costs are. Again, and I think that's the question. Somebody made a comment, it's very confusing. It shouldn't be, because this is critical information, and you'll have an opportunity, on the call next week, or the mandatory meeting in December, to ask this question directly. Probably the in-person meetings are best, because they have, Babatunde and Mr. Lucero are going to be there, and ask them directly. What do we do? So, okay, any questions? Or folks out there, any questions?
We didn't get any from anyone on the call, but I would like you to clarify a couple of things. Again, I'm just just in case the group has questions and they're just, they haven't been able to ask the question. I'm going to ask you some questions that I get asked frequently, and so that maybe you can just review them. On this sheet, if you could you scroll back up to the top section where we're talking about capacity, static capacity, and dynamic capacity. This sheet is pretty much calculated for you if you filled out, the previous tabs. But you'll notice there's some real key parameters here. And Victor has done a good, he's talked to you a little bit about what is your episode duration, it's weeks, and you look at 48 and you think, well, 48, but we're open 52. So maybe could you go through and explain those, because these items that are white, they're not yellow in this little box, those you have control over.
Yes.
So could you explain what each of those numbers are so people can, make some decisions about how to fill that out?
Well,
and you did a good job with caseload. I don't know if people have necessarily talked. A lot of the providers that I talk to, they don't really think about how many people each, full-time equivalent is, what their caseload is. But if they look at it again, they can kind of say, wow, so-and-so sees about this many people, and you can add that in. Even as individual session hours, people have questioned, but that really means that, standard individual session hour is 1, a standard group session for our organization is 90 minutes, that's why it's 1.5. But if your standard group session is only an hour, then you would change that to a 1. Your average attendance per group, I know that some people, 7 seems pretty low because they're really trying to get 12 people in a group, but have you already accounted for no-shows, or is this just really what you think the people just, sign up 7 people?
Right, and that's,
schedule.
Yeah, and again, you will know that, as far as what you schedule 10 and you get 6, so is that, you get some sense of what, and like I said at the meeting last week, I mean, group is where you use your staff most efficiently, and where you capture the bulk of the money. So here's group counseling down here. That's $862,000. That's more than any other single service. Way more. So that's, I think group is something you want to keep your eye on, because, like I say, that's a service where your staff are working most efficiently, where a group counseling is sort of the basis for a lot of the work we do, and and you simply cannot make enough money doing an individual counseling because it takes a lot of time. You spend an hour, you see one person. You do a group, hour and a half, and you see 7, 8, 10 people. So again, much more efficient. And while the rate is higher for individual than it is for group, because of the multiple, you just make more. Like you see here, this is where the bulk of the revenue comes from. So anyway, static capacity. So really, what this is that's calculated. So it's 7 FTEs times 20 persons on the caseload. So that's 140 people. If it was caseload size was 10, that'd be 70 people. Or if it was 30, you go way up. You have 210. So that is, again, that's it's like the yearbook. You take the snapshot of how many clients, and I don't know what would make, are active in the program at a given moment. And probably better take a snapshot of the chart drawer to see, okay, how many charts you got in there of active patients. And so that's what it comes to. And and if you've got some standard for saying, okay, the counselor can expected to have X number of clients on their caseload, that's your policy. That could change if people are dealing with clients who need a lot of it'll even within a given individual's caseload. You got some newcomers to treatment, high maintenance, need a lot of work. On the same, so you got 5 people who are brand new. On the other hand, you got 5 people who are kind of start gliding out the door, who need a lot less work. And so it's something only you can know. Is what is the best client mix and number per individual counselor. So that's the static capacity, which an easier way to think about it is where it's like in a residential setting or even NTP. You're licensed for a limited number of slots or a limited number of beds. So you've got a 10-bed facility. Your static capacity is 10. Period. Because that's what your license is. If you turn those beds over, so your length of stay is a month, then you turn that caseload over 12 times a year. So your dynamic capacity is 120. More like a detox, let's say, but short-term stabilization. So it's the same sort of principle here, although it's a little, squishier, because the caseload size per counselor can vary, depending, and length of treatment, actual length could vary a little bit too. As I say, you'll know a lot. All of us will be a lot smarter about this a year from now. But that's, or in the taking it back to the residential setting, if the average length of stay is 90 days, then those beds turn over 4 times a year, and you know, so 10 beds times 4 turnovers, that's dynamic capacity is 40. And you can see where length of stay has an impact here. So the same deal for outpatient. If your average length of stay is 4, and as I showed here for the primary phase of treatment is 16 weeks, 4 months, then you would turn the caseload over 3 times a year. And again, that's why I'm thinking I want to take out or somehow separately display recovery support, because it I think modifies a little bit, gives some of these caseload static and dynamic capacity, and to do that separately for each level of care, for the outpatient level of care and for the recovery support level of care. So in reality, if we looked at, if we're just looking, if we took recovery support out, you've got a 16-week length of stay, ideally. You know, on the average, who knows, it goes down to 12. But we start out thinking, okay, it's 16 weeks. That means the caseload turns of 140 people turns over three times a year. And so the dynamic capacity, we'll see, would be 420. You see, and again, you know, this is a model. I don't know if I said that at the meeting last week, but you know, there's a saying that, you know, all models are wrong, but some are useful. And the person who actually said that, although I'm not sure what they actually said, but it's you know, all models are imprecise. No models are perfect. You know, it's like looking at a Google map and the street you want isn't there, or you see a street is there that you isn't. You know, they are not perfect, but they, I think, are guidelines or guides to how we move into the future. And this is what this is all about. And we take our best thinking, our best data, put some numbers in here and see what that tells us. And what I find is helpful too is putting in kind of just to see, you know, extreme values. So, you know, if caseload goes down to 10, well, you know, revenue is 1.3 million. You're in trouble. You know? So caseload is important. If caseload is up to 30, you know, you're bringing in $4 million. Now that may not be possible, but again, it just shows you the impact of some of these parameters on operations, and you know, operations and revenue are very, you know, very closely linked here. Okay.
And Victor, we have a question. Yeah, we do.
Okay.
There's if some of our group sessions are 60 minutes and some 90 minutes, how do we determine the value for the group sessions in the hours field?
Well, you know what you would do then, and I don't know how you would do that exactly, but you know, you'd have to do a little, and I could help you with this. But if you're, you know, this reminds me of an SAT question. You know, you do, in the course of a year, you do 600 group sessions, you know, and 200 of those are 1 hour and 300 are 90 minutes. What's your average? and basically you calculate that. So what you would have up here would not be 6, but, you know, 4.5. And you can do that, and then the math will work out and propagate throughout the spreadsheet. But you'd have to do that calculation. Okay, what's the average duration of a group? Knowing that, you know, X number are 4 units, 60 minutes, and Y are 6 units, 90 minutes. But then you just, once you know that, you know, then it's you just plug it in here and everything will calculate out throughout the spreadsheet. And again, we can help you figure that out. And actually, if we do this, 4.5, Yeah, it didn't change anything. but anyway, yeah, so we can do that. All right, just in the interest of time here, which is running short. So anyway, so this is looking at the revenue. You know, if
and
you
Victor, before you move on, sorry, I have one more question or one more observation before you move on, and I'll make it short, is that the questions that people had about, you know, no-show rate, or maybe were questioning disallowance rate, and we were talking about really keeping track of that. SAPSI is, you know, training people who are going to be looking at key performance indicators, and they're asking for each agency to sort of select who should be involved with, you know, collecting this information. But that's information that is most generally or most likely going to be included on one of your agency dashboards. So think of that when you're trying to think about those key performance indicators in your organization. Disallowance and no-show rate is huge. Yeah.
I mean, all this information is going to be in SAGE, whether it's entered directly, you know, in terms of looking at service units, or calculated on the basis of what's in there, like your, you know, show rates or disallowances. Yes, that's thanks, Amy. That's an important thing. All right, so now let's see. Now we answer the question: Do you have enough staff to pull this all off? So again, similar to what we had on the previous page, these are all calculated cells. Actually, everything's calculated here. You know, the service types, total annual sessions, annual staff hours, and now we sort of move in the other direction. Is how many staff hours per week you have sessions, but how many staff hours a week do you need to do all this work? And so the total we get here is 432. And so then, and maybe this should be at the top, but anyway, then what we have here is a staff productivity model. And so the first thing to do, and this is what you would put in, is, and how I talk about it is, how much is, you know, paid leave, with holidays, vacation, average sick time, etc. How much time is spent in program support? Now that's everything. These are kind of a broad term for any non-billable activity. So, you know, staff meetings, charting, training, no-shows, clinical supervision, et cetera, et cetera. And so what's left, you know, is 1,400 hours, or about 2/3 of their time, is expected to be spent in direct service delivery, which is billable service delivery. This column just calculates the percents for you. This then, on the basis of those percents, how many hours per week per FTE? So it's 1,400 hours a year billable service. That boils down to 27 hours a week in session. And of course, this is where no-shows kills you. And then the total budgeted hours. Now this comes out of the budget. So for your 7 FTEs. So it's, you know, 14,560, which is 7 times 2,080 hours. And with out of 14,560 hours is 67% of that is 188 hours. So that's what your 7 FTEs, what it all boils down to, what they can provide in the course of a year. I mean, course of a week. And we see up here we calculate is 432 hours. So you're short here. You know, you've got about, just around here, about 200 hours available to do direct services, but based on your service model, you need 432 hours. So what this would involve, and it's a little complicated, I tried this beforehand, but really what this means is a service model. There's a discontinuity between the service model and the staffing. And as I mentioned earlier, this is, as I look at it and see the number of units per week, and I will put in an hours per week. So that's 10 hours. Right here, week 4, the 10 hours a week in treatment. I don't know if that's, and actually some of these are need to be changed because that's in excess, your IOT, if you're doing more than 9 hours a week. So what this would tell you, if this was indeed a real service delivery model, is it's too much. One, I think it's, I just look at this as, I don't know, and you could, know that from your own experience, how many hours a week can you keep a counselor, keep a patient, on site, and then, and coming in every day for services. So this would, and I was going to try to make these adjustments, but it mixes things up. But what we need to do then is starting here. So maybe there's a little less time. The assessment intake, maybe that's 4 hours. So that maybe it only happens on the first week. These groups counseling hours go down to something more realistic. And what we'll see, and I didn't change this enough to you can see this. Well, it'll change a tiny bit, but it'll change these numbers here. So is there, as your intended aggregate hours of service delivery go down, you'll get closer to balancing this out, or you could add staff. So there's where you get into this balancing act, and what I find is generally, a couple or 3 iterations through this is necessary before you kind of get it. You feel like, okay, this all seems to balance out. Staffing is right, looks good, budget's good, and service delivery is good, and based on this amount of staff we have, they're around. They're able to do this much work. I've talked to several providers in LA because my first edition of this, and every time I do this, it changes a little bit. But this was like, I think it was 1,600 hours, and everybody said, "Oh, no way, no way we could do that." And so I took it down to 14. And others may think, well, that's, but I have to say that in county mental health systems, where you've got, county employees, oftentimes unionized, that's a standard in county mental health systems. They got to spend a third of their day doing billable work. So, and that's just sort of the way it came out here. I wasn't really looking at that as the benchmark, but so anyway, that's where we are with that. Well, I will send this out to everybody who's on the call. Send out links to the CMS provider reimbursement manual, and make a few little changes like I talked about. Please let me know as you look at this if you want to, this thing about separating out the recovery support from the outpatient services, like I did here. It's actually display that on a maybe separate tab or something, just because they're kind of 2 different services. The expectations on the utilization of staff time and patient interaction is much different than it is for primary treatment. I'm kind of talking myself into it as I say this, but do let me know what you think. So Amy, are there any questions, or because we've come to the end of our time here?
Yes, Victor, I'm sorry. I was on double mute. One other question.
Yeah.
There was a question about he didn't address the field I was referring to, and that was the question about the 60 and the 60 and the 90-minute group. So
yeah.
when you, and I think to clarify then, just to make sure, what happens then, if you go back to the service model worksheet and you would adjust your group counseling session to 4.5 hours, then on the revenue forecast spreadsheet tab, I'm sorry, if you want to click on that, Victor, change that to 4.5, because we calculated, we decided that would be the average.
I just made that up, but yeah, right.
Yeah, and again, you'd have to calculate that in your own organization. Then if you want to pop back up to the top section, way up, you have to keep going farther.
Yeah.
Yeah, and you'll notice it'll change your total sessions, and it wouldn't be necessary then to change the line number 9, because you would still say that you were calculating at a 1.5 session, correct? Or what they're asking then is, would you also need to change that cell to reflect a different amount?
Well, so let's say maybe it's 1.25. Again, I just, you know.
So yeah, that is better clarification. There's a couple of spots then that you would need to change it. Yes, and it brings up a good point. I think when you're looking at service model, you know, Victor has it calculated at 4 sessions and 6 sessions. Again, you have the flexibility of changing that one whole line item across the top to reflect a different amount of time for your sessions. But then it did a really nice job of helping us pinpoint exactly what other areas on the spreadsheet then you need to adjust. So thank you very much. That was Derek. Right. That was great.
Yeah, thanks for bringing that up. Yes. So, yeah.
And then there's a question. Okay, yeah. So, yeah, no, you finish. Sorry, Victor.
No, okay. So again, if you want to modify it, and I think I may modify this anyway, just to make it compliant with outpatient attendance requirements. So 9 hours a week or less. And some of these I noticed are
a little high.
A little more. Yeah.
Yeah. And so that's a good point too. When in doubt, the first place to start is to make sure that you're accounting for at least the minimum that you're supposed to provide. And then you can always add more sessions, because I don't think anybody's saying too that someone can't have more sessions if it's deemed medically necessary.
Well, yeah, although you may slip in, and I don't know what the state's rules on this will be, but then you could slip into IoT territory in terms of outpatient. So
yep, exactly. Yeah.
For a couple of weeks, they're getting 12 hours a week, and then they're back down to 8, let's say. I wouldn't say that, that you're now, for 2 weeks you're now in an intensive outpatient program, but but that sort of thing
right.
happen.
Yes, and it may be necessary. So those are sort of, for starters. Again, this is a great way to start to estimate, especially the question that we get over and over and over again is, do I have the right number of staff? Am I sort of in the ballpark with my expenses? So if you do this, and again, you could easily take the information you have from June, July, and August, if that's sort of your standard practice and you haven't really altered your service continuum and you've been treating people like you always have, keeping in mind that as of July 1st, you were supposed to use the new minimum standards and, reflect your program to be more patient-centered. You can start by just saying, this is kind of what we do. And then looking at it, once you compile all the data, that's really when you get to be creative and you get to really start to identify well, what's going to happen if we decide that we are more patient-centered and we are understanding that we're certified to do intensive outpatient and outpatient? Then you have sort of this new issue of how are we going to coordinate that care? And I think that was one of the topics that Will touched on, is we have to coordinate care internally as well as externally. So does that sort of information come out in your case review meetings, and how are you acting on that, and who's accountable to act on the idea that, you know what, we're not patient-centered, we're not really giving people diverse care, we still do sort of have programmatic approach to this, and that too is going to be a problem because you could get some of your revenue taken back if it's deemed, you know, when the quality assurance people come around and say, this doesn't look patient-centered, everybody gets exactly the same thing. So you have an opportunity to look at this, put the information in, but then you also have to be accountable to track it and see if what you put in there is really true, or if you need to make some adjustments, and then assign someone to track this information using this template, look at your key performance indicators in SAPC, and then go back and see if you really did do a good estimation, if this is what you're going to use to do your projection for your budget. You will have to kind of hold somebody accountable, the executive director. As an executive director, this is something that I would watch, as well as I'm sure finance would, because it's going to be critical. That's my little lecture, but yes. And then, you know, we also know, we have some question here about the problem is auditors generally do not know much on budgets, and there is no specific analyst for financial issues for the agency. And, you know, right now I think that's one of those questions, and some of the questions I think are going to get fielded maybe later during some of those mandatory monthly meetings with SAPC. I know if any of you have had the opportunity to do their SAPC calls it a TRR, a treatment readiness and review site visit, you get some great one-on-one time to answer some of those questions about your specific needs in your organization. There is a bit of a catch-up period between all the county staff and all the state staff. So having a place to document it, understanding what's going on in your business will help you educate those people who have to come in and do the audit, and then also bring up specific questions, and you'll have data to back up what it is that you would like to address.
Great. Well, thank you, Amy.
Yeah, because what we're really finding is that those TRRs, they're asking you to do the outpatient treatment, and that's, you know, to do the spreadsheet, to fill out the spreadsheet. And someone made a comment too that it's important for our team to find out from county what programs need to do. And to be perfectly frank, I feel like I have a mastery of the information that's out there now. I always, whenever I have a question, I go back to the SAPC website. I look at the LA County Providers website. I look at the bulletins. I really scour the documentation and make decisions based on that. And sort of, unfortunately for Victor and I right now, it's sort of global, and we're not really specifically sure of each of your program parameters. But again, if you have questions about this, this is definitely something that you could do a deeper dive with your coach. And then also I'm going to ask you to, you know, go back and look at the LA County website and see if your question's answered. There is a lot of communication and a lot of what do I want to say, due diligence occurring at the county office, because the financing is extremely different. So making sure that the contracting staff, which is, you know, Anton and Daniel and Baba and Robert, are all on the same page. And there's, you know, this is new to everybody. And so some of this information is not yet set in stone. So it's a good time to advocate and speak up and ask questions, because that's the information they need in order to set policy and standards. And I certainly do my best to keep up. And any specific questions people have, you know, but I do need to go back to SAPC with really specific questions How do I do this specifically? Those are questions we're perfectly willing to go back and field and try to get a better understanding of also. So keep those questions coming.
Okay, well, we've come to the end of our time here, and I'd like to thank you all for joining us today. I hope you found it useful. We'll get the information out. Today's Friday. We'll get it out over the weekend, so you have it all on Monday. And like I say, yes, as Amy was saying, we're available to help as you start to work with this. And if you got questions about, you know, as we had about the group counseling, you know, we're available to help you do that, both to fill it out and understand the concepts that underlie all the numbers that show up in this spreadsheet. So thank you very much. You know, more to follow. Good luck, and we're here to help you work through this all.
Yeah, thank you very much.